Audio recording for this meeting has begun.
Okay, sorry about that. This recording will be made available to all who register for the webinar. I will ask that if you're not speaking, that your phone line or computer speaker is muted, just to limit the distractions on the phone line. If you have questions or any technical help during this call, please utilize the chat function in the bottom right-hand corner of your screen. You can also private message me or my colleague Neil Rana, who is listed as a host. All questions will be addressed at the end, but we will keep a queue, so please send them our way as they come up in the chat box. I also want to flag for you that there is a box called Files on your screen. In this box, you will find the journal article presented, so you can download and reference it. For our agenda today, we will start with an introduction of our presenters. We will then move into the article background, methods, and results, followed by a time for discussion and engagement, not only with the presenters, but with you all as the participants as well. There will be ample time for questions at the end. So without further ado, I'll hand things over to our presenters for the day to discuss their recent article called Integrating HIV Testing into Syphilis Partner Services in Mississippi to Improve HIV Case Finding.
Thanks a lot, Leandra, and thank you all for the invitation to present here at the webinar. And we're going to be, so my name is Tigran Abunjin, and I'm from the University of Washington. Also on the phone are David Payton, Kendra Johnson, and Christy Lewis from the Mississippi State Department of Health. And we're going to be presenting on a project that was evaluating the integration of HIV testing into syphilis partner services in the Mississippi State Department of Health. And this was a collaboration between the Mississippi State Department of Health HIV Program and the University of Washington, and was funded by an STD app supplement from CDC. So to advance slides. Okay. So I'm sure many of you on the call are aware that rates of HIV and STDs in the southeastern United States are among the highest in the country. So the map on the left shows rates of HIV diagnosis in 2016 in the U.S., and then the map on the right shows rates of primary and secondary syphilis cases in 2016. And you can see that some of the highest rates are concentrated in the southeastern part of the country. Among these is Mississippi, which ranks in the top 10 in terms of both HIV rates of HIV diagnosis and syphilis cases, and also in terms of gonorrhea and syphilis cases. In addition, Jackson, Mississippi ranks in the top 10 in both rates of HIV diagnosis and rates of AIDS diagnoses as of 2015, and in fact it was #1 in rates of AIDS diagnoses. Which really show that there's a need for interventions that kind of target HIV care delivery and HIV prevention, and a need to capitalize on any opportunity that we have to improve these activities. So one opportunity to kind of improve HIV prevention efforts is by integrating HIV testing into syphilis partner services and more broadly STD partner services. So the rationale for this is that syphilis is a known risk factor for HIV acquisition, and we already see high rates of syphilis and HIV co-infection in the U.S., particularly among MSMs. As of 2017, about 45% of reported primary and secondary syphilis cases among MSM were among individuals who were HIV positive. And so the idea is that if we offer HIV testing through syphilis partner services, we should be tapping into a population that is at high risk for HIV and should hopefully identify a lot of cases who we can then link to care more quickly. In addition, the DIS are already contacting partners of early syphilis cases as part of syphilis partner services activities as well. And so adding HIV testing to these activities kind of makes logistic sense since you're reaching out to people who are at high risk of syphilis and you're already talking to them anyway. So adding HIV testing kind of improves the efficiency of both the HIV testing activities and the syphilis partner services activities. So as I mentioned, this evaluation was part of a larger project to improve, to integrate HIV-related activities into Mississippi State Department of Health STD Partner Services Program, and was a collaboration between the Mississippi State Department of Health and the University of Washington. And the goal here was, for the aim that I'll be talking about today, was to evaluate the utility of STD partner services, and in particular syphilis partner services, as a means to increase HIV testing and case finding. Okay. Before jumping into the evaluation, I wanted to give a brief overview of how syphilis partner services works in Mississippi. Like many states in the U.S., Mississippi has mandatory reporting for syphilis diagnoses. So when a new diagnosis or a positive serological test for syphilis comes up at a medical provider or a laboratory, it's reported to the health department. And this gets entered into PRISM, which is Mississippi State's STD disease surveillance system. Cases in PRISM get assigned to a DIS for investigation, and the DIS will attempt to contact index cases and conduct a full partner services interview to verify treatment, collect demographic and risk information, and identify sex partners. The DIS will then reach out to named partners to test them for syphilis and collect demographic information. In addition, they will offer all partners treatment for syphilis at the time of syphilis testing, a process called epidemiologic treatment. And this is done to minimize delays in treating truly infected case patients and to ensure treatment of people with incubating syphilis. And then for partners with new early syphilis infection, the DIS conducts a full partner services interview, similar to the index case interviews, to verify that they get treatment, and then to elicit additional partners of the partners, and that kind of starts the process up again. And then as of 2014, the DIS started offering HIV testing in the form of referrals to the STD clinic for rapid HIV testing to all partners of cases of syphilis. In addition, all of the DIS were trained to conduct blood draws in the field, and so they, as an alternative to coming to the STD clinic, partners were also offered an HIV blood test in the field. So for the purposes of the evaluation, we started by identifying all early syphilis cases and their partners from July 2014 through December 2016. We started at July 2014 since that was when HIV testing was first integrated into syphilis partner services. We defined an index case as a case record in PRISM with a diagnosis code for primary, secondary, or early latent syphilis. So those would be the diagnosis code 710, 720, and 730. And we excluded index cases who were newly diagnosed with HIV within 30 days of early syphilis infection. Since we were interested in HIV case finding through syphilis partner service specifically, we felt that index cases who were newly diagnosed with HIV would have received HIV partner services, and their partners would have been tested for HIV regardless of the index case's syphilis status. And that's why we ultimately ended up excluding these cases. We defined syphilis testing among partners as evidence of a syphilis serologic test in PRISM after being named as a partner. And we defined a new syphilis case among partners as a partner with a diagnosis code for primary, secondary, or early latent syphilis after being named as a partner. We defined HIV testing among partners as evidence of an HIV test within 30 days after being named as a partner. And new HIV cases were defined as partners who had an HIV diagnosis within 30 days after being named as a partner and no evidence of previous HIV diagnosis. To identify these HIV outcomes, we linked PRISM data with Mississippi's electronic lab reporting database, which is called Apollo. and EHART data to ensure that we were identifying all reported HIV tests and all HIV diagnosis, including previous history of HIV diagnosis, and to ensure there were no gaps in our data. And then we looked at a series of traditional partner services metrics or partner services evaluation metrics, and these included partners named and contacted, the partners who were epidemiologically treated, which we defined as the number of partners who did not test positive for syphilis but received preventative treatment after DIS contact. We also looked at the number of partners who were brought to treatment, which we defined as the partners who tested positive for syphilis and received treatment after DIS contact. And also the number needed to interview, which was the number of index cases needed to interview to identify one new case of HIV or syphilis among partners. And finally, we looked at the test positivity rate to see how the success of testing among partners who were actually tested for syphilis and HIV. And this was defined as the number of partners who tested positive for syphilis or HIV divided by the number of partners who were actually tested. So jumping into our results, in total over this 30-month period, we found 1,619 index cases with an early syphilis infection. Of these, 1,535 were interviewed by DIS, and this yielded 2,267 named partners, of whom DIS contacted 1,867. To give you some insight into the index case characteristics, most of the index cases were MSM, about 2/3, and about 1/3 were previous HIV positive cases, and majority of the index cases were also Black. Among the MSM cases, 53% were previously HIV positive, and you can compare that to about 5% of men who have sex with women and women. So this slide shows our partner services outcomes, and here where the graph shows the partner services indices, and we define the index as the outcome divided by the total number of index cases, or 1,619. And so we had 2,267 partners named, and then the index would be 1.4 partners named per index case. So of the partners named, 1,867 were contacted, which was an index of about 1.15 partners contacted per index case. We had 0.29 partners interviewed per index case, and these are partners who were provided a full partner services interview, and it's only among partners who tested positive for a new syphilis infection. There were 895 partners who were epidemiologically treated, and these are partners, again, who were not positive for a new syphilis infection, but who received preventative treatment. And there were 448 partners who had a new syphilis infection and were brought to treatment, which had a brought to treatment index of 0.28 partners per index case. And then jumping into our syphilis and HIV case finding outcomes, of the 2,267 partners who were named, 1,507 of them, or roughly 2/3 of them, were tested for syphilis. And of these 695, we identified 695 new cases of early syphilis. And our number needed to interview was 2.2, or in other words, it took 2.2 index case interviews to identify one new early syphilis case among partners. In terms of our HIV case finding outcomes, there were 1,479 HIV negative partners who were contacted by DIS. Of these, about half, or 741, were tested for HIV, and we found 24 new HIV cases among these partners. And our NNTI was 64, or in other words, it took 64 index case interviews to find a new case of HIV as a result of syphilis partner services. So our syphilis case finding outcomes didn't vary much by race, gender, and gender of sex partners of the index cases or the index cases HIV status, but there was quite a bit of variability in the HIV case finding outcomes by index case characteristics. So the graph on the left shows the number needed to interview to identify a new case of HIV among partners by the index cases HIV status. And as you can see, the NNTI is much lower for index cases who were previously HIV positive compared to partners of index cases who were HIV negative. Similarly, among Black MSM, the NNTI was much lower than among partners of index cases who were white MSM. And so 2 slides ago, I noted that about half of the partners who were eligible for an HIV test were actually tested. And we wanted to look at this by subgroup. And across all of the subgroups that we looked at, we kind of consistently saw that about half of partners who are HIV negative actually received an HIV negative test. But as you can see, there's quite a bit of variability in the test positivity, as indicated by the purple bars here. So among previous partners of index cases who were previously HIV positive, about 15% of partners who were tested for syphilis, tested for HIV, actually tested positive. Similarly for MSM, 6.2% of partners who were tested for HIV tested positive, indicating that among these groups there was higher rates of HIV test positivity than among other groups. So to summarize, syphilis partner services yielded a substantial number of new syphilis cases and HIV cases, and HIV case finding was highest among partners of Black MSM and index cases who were previously HIV positive. The high HIV test positivity among these groups, so we saw also a high HIV test positivity among these groups, indicating that if we improve HIV testing rates, we could also see an increase in HIV case finding as a result of syphilis partner services. And then to kind of discuss some of these findings in a little more detail, we saw low syphilis NNTI in Mississippi compared to other jurisdictions. And this may be due to the high burden of undiagnosed syphilis in the area, and syphilis partner services may be tapping into high prevalence networks, which is why we're detecting a lot of new cases among partners. But I think more importantly, this may also be due to Mississippi's prioritization of syphilis partner services. In our conversations with the DIS and the staff at the health department, we found that the DIS recognized that partner elicitation and testing are very important aspects of syphilis partner services, and the low number needed to interview reflects the DIS's efforts. And I don't think I can overstate enough what a tremendous amount of work that DIS put into syphilis partner services, which is really great. In contrast, we saw that the HIV outcomes in Mississippi were not as good as other jurisdictions. And this could be a reflection of low testing among partners. And if we increase HIV testing among the partners, we could lead to improved HIV case finding that's similar to other jurisdictions. However, the low testing rates that we saw could also be a reflection of data issues, and in particularly reporting of negative HIV tests. Since negative HIV tests aren't reported systematically to the health department, the tests that we're missing could primarily be negative tests, and our low test rate that we're seeing could be a reflection of missing data. Basically. So we may be underestimating the amount of HIV testing that was actually done during this time period, and future research is needed to determine if the low rates of testing are a reflection of data issues or true barriers to HIV testing among partners. Our results also highlight syphilis partner services as a key HIV prevention opportunity. Through STD Partner Services, the DIS were able to interact with 719 HIV-negative MSM over a 30-month period, including 538 Black HIV-negative MSM. This could be an opportunity to integrate other high-impact HIV prevention activities, including PrEP uptake, of which there are major racial disparities in PrEP uptake. And Syphilis Partner Services could serve as a way to kind of reduce those barriers and disparities. In addition, for HIV-positive MSM or HIV-positive persons in general, Syphilis Partner Services could be a means to improve relinkage to HIV care, since it is an opportunity to interact with potentially a large group of people who are HIV positive and who may be out of care as well. And our findings also have some important implications for STD programs. I think one, it highlights that integrating HIV testing into Syphilis Partner Services is an effective strategy for identifying people newly infected with HIV. And in addition, Syphilis Partner Services can be leveraged to improve PrEP uptake and HIV care delivery among HIV negative and HIV positive people, respectively. In addition, I think our study as a whole presents some standard outcomes and a framework for evaluating STD partner service programs that other jurisdictions can use and that we can then compare across jurisdictions to see how well this works in different settings. And some future directions that we want to take with this work are to really look at the facilitators and barriers to integrating HIV testing into Syphilis Partner Services, and also to further evaluate the impact of integrating PrEP referrals and HIV relinkage activities into Syphilis Partner Services. As of 2017, the Mississippi State Department of Health actually started integrating PrEP referrals into their STD Partner Services programs, and also has started integrating HIV relinkage activities into their programs as well, and evaluations of both of those activities the activities are underway. So I'd also like to take a moment to acknowledge my co-authors who couldn't make it to the call, including Christine Cosreporter and James Stewart, and I believe Christy Lewis is on the call with us today too. And also to thank the Mississippi State Department of Health, DIS, for all of the tremendous work that they do on Syphilis Partner Services. So, thanks.
Awesome. Thank you so much. And that was a great presentation of the evaluation that was conducted in Mississippi. And I have some group discussion questions here, but I see that Matthew Golden wrote in the chat box. We can go ahead and address this question. He asked, among the partners of previous positives, were you able to look at partners of persons who were suppressed versus those who were unsuppressed?
We didn't specifically, in this evaluation, look at the partners of persons who were suppressed versus those who were unsuppressed, but I will send that in a different evaluation. We did start looking at those, and I will send you that information after this call.
Thank you so much. One question that I wanted to dive into first, just for all of the participants to just get a little bit more engaged with each other, is regarding DIS. And I know that DIS play a really big role in health departments across the country when it comes to STD and HIV prevention. But I'm wondering, for all of you on the call, what specific strategies has your health department employed with their DIS if you all have gone through integration of HIV testing into Syphilis Partner Services? And maybe not necessarily Syphilis Partner Services in particular, but in general, this integration of HIV testing into that system. Any kind of strategies, I would love to hear those, especially as more programs are working to get their HIV and STD divisions more fully integrated in general. So feel free to unmute your phone. You can talk that way, or either submit answers via the chat box. And feel free to keep submitting other questions as well as they come up. We'll give it a second. Anyone wants to hop in there for that question?
Hello, this is Karen Sarita from Texas.
Hi, Karen.
Hi, how are you all? So in Texas, we are a decentralized state, meaning that we contract with local and regional health departments, but we're also an integrated state and have been for many years. So part of the requirement for our DIS and our local and regional health departments is that we require DIS to document an HIV test. And vice versa, whenever we have a new syphilis infection, we require all staff to document the most recent HIV test. So that if that means that they need to offer an individual an HIV test at that time, then they will, and then we'll document it. And for all new HIV cases, we also require DIS to conduct a syphilis test. And oftentimes, the HIV diagnosis was done with a different provider, so that means that the DIS will have to do a blood draw when they conduct the interview if they're able to. So that's really helped us to identify or at least have testing history. Like Tigran spoke earlier, for those, we also do not require, by law, laboratories and providers are not required to report negative HIV tests, so that has helped with increasing at least our knowledge of a most recent HIV test.
Thanks, Karen, for that input. Have you all seen any barriers or challenges to implementing this? You've mentioned that the staff are required to document an HIV test. With the implementation of that, have you seen any challenges that your staff have noted?
No, we haven't seen any challenges. We also do, staff can also conduct a rapid test in the field for some of our regional health departments that are more rural or the DIS has to travel we also allow them to do syphilis health checks, so that's helped with gaining some additional information from some of our clinical sites that we fund. If the DIS doesn't talk to them, it conducts a telephone interview, but they go to another clinical setting, we offer that as an additional resource to some of our regional. I would say we really haven't heard of any specific challenges to implementing it, and we've seen a high percentage of reported HIV test results as a result of having this standard.
Awesome. Thank you so much for that. I see that Brett writes in the chat. Oh, he's still typing. Maybe I'll give you a second, Brett, to finish your thought. Any other thoughts in the meantime on strategies that you all are employing where you are to, with your DIS there, to integrate HIV testing into your partner services? And maybe any challenges or successes that you also have had, as Karen brought up in Texas. Brett says, California moved HIV status/testing from the syphilis interview to standard follow-up in their surveillance system in 2014. California is also currently moving HIV and syphilis into the same surveillance system to integrate follow-up and partner services. Also wondering about challenges or successes there. So I'm sure that's a big task. Any other thoughts around this? I'd love to hear. Any other questions for our presenters as well? on anything that Tigran presented on. We also have folks from the Mississippi State Health Department on that can also answer questions.
Hey, this is Saul Rojas from Texas. On your graph, you presented two groups. One is white and the other one is blacks. Can you tell us a little bit more about other minorities?
Sure. I think if we go back, so a majority of the index cases were black, and then a smaller subgroup were white, and we really didn't see a whole lot of other minority groups. And we didn't find any HIV cases among partners of index cases from other racial groups, which is why we didn't present them in that graph. But yeah. In terms of syphilis case-finding outcomes, NNTI range from about 2 to 3 across all race groups. So it was pretty similar regardless among white, black, and other race groups.
Thank you.
Yeah.
You have a particular question around if those at the State Health Department have designed any special initiatives targeted toward Black MSM. I know, Tigran, you mentioned in the evaluation you found that Black MSM had a higher HIV test positivity, and most of the partners that were interviewed and contacted, I think on this slide, yeah, that most of them were also Black MSM. So I'm wondering if there have been any talks around special initiatives to target this group as far as, you know, testing outcomes or just increased testing in general.
Okay. I'll defer to Kendra and David to answer that question since they have more insight about what the program is doing.
Kendra, did you have any thought on that before I speak? Okay.
Kendra, I don't know if she's on or not. Thanks,
okay.
David.
Can you hear me?
Yes.
Okay. All right. Well, this is David Payton. We have noted that, you know, we have a higher percentage of MSM that are testing positive, and we are working with our HIV prevention folks. Well, we're working with the HIV prevention folks to look at, I guess, interventions where we can target higher target higher population where, you know, MSM reside. And so we don't have any specific interventions other than trying to get into the social groups that we when interviewing when the DIS are interviewing MSM, just trying to expand those social networks to try to identify more individuals that would benefit from testing. But those are basically the only interventions that DIS have been involved in.
Thanks, David.
You're welcome.
Any other questions for our presenters on anything that has been talked about with this evaluation? Awesome. I'll give it another second if folks want to chime in. If not, that's okay too. I have our presenters' email addresses here on the slide. As you can see, I also have my email address if you have any general questions about the Journal Club. I want to say thanks so much to all of you who attended today. Feel free to reach out for any additional questions. In the chat box, there will be a link for a very brief webinar evaluation that you can, I will ask that you fill out just to inform future webinars, and you'll also be redirected to the survey once I close out the webinar. But yes, this information is really important to help us guide future webinars as we are working to plan them. As I mentioned previously, today's recording and slides will be sent to all of those who have registered, and I will ask that you be on the lookout for the blog related to this article in March, and then the next Journal Club meeting in April. And before I sign off, any last lingering questions for our presenters? Thank you so much, T-Ran, and thank you to all of those who are on the line from the Mississippi State Health Department as well. Thank you so much.
Thanks for having us.
Thanks. Everyone enjoy the rest of your afternoon and the rest of your week.